continue to hold. Your call is in sequence.
Thanks for calling help desk. How can I help you?
Yes, hello. I'm calling because I've phishing, and so I received an email saying that I need to call you because you changed my password.
Okay, I'll change your password. Just give me a second, okay? Just hold on.
Hello, everybody. My name is Laurent Brochard. I'm intensivist and also scientist working at St. Michael's Hospital in Toronto. I'm the director of the Interdepartmental Division of Critical Care Medicine. And we have prepared for you a series of lectures trying to explain the basics of mechanical ventilation over 4 days. So every day from 6 p.m. to 7:30, we will have 2 or 3 presentations discussing the different aspects of mechanical ventilation. And what we plan to do is to have approximately half of the time of each lecture for question and answer. Of course, we are not sure that this time is sufficient. You have my email, and I think everybody will show his email address. So don't hesitate to continue the discussion later. And if we see that we have so many questions that we need to do other sessions, we will be happy to do that. So my first presentation today is about the basics of understanding the interaction between the mechanical ventilator and the patient by looking at the pressures on the ventilator. Basically, the ventilator is pushing air into the chest and into the lungs of the patient, and this generates pressure. And what I'm going to discuss today is how do we interpret this pressure and what do we do with it? Because as you will see, these pressures are fundamental ways to monitor the patient and also to adjust the ventilation. So nothing is specifically relevant, but I'm working with a number of companies to get research grants or mostly equipment, and these companies are listed here. So for those of you who are not familiar with mechanical ventilators, these are devices which needs a high pressure source, and they deliver the gas under pressure. And when I say gas, it's usually a mixture of air and oxygen. So for ICU ventilator, the pressure source is usually the wall pressure, which is much higher than the pressure delivered to the patient, or it can be a pressurized tank of compressed gas. You may know that small portable ventilators, like those used at home or for transport, use their own turbines to generate pressure. And in fact, we see more and more of relatively small ventilators which do not need compressed air or compressed oxygen, but which generate themselves their own pressure. The limit is usually they cannot go to very high pressure, but for many patients, this is sufficient. So pressure on the ventilator is an essential monitoring tool. On this slide, you have an example of one ventilator, and all the ICU ventilators now have a screen like this one, giving numbers, but also displaying waveforms. On the right part of the slide, you see an example of the 3 typical waveforms, which are the airway pressure, the flow, and the volume. And what we call airway pressure is the pressure measured at the airway opening at the Y piece, very close to the endotracheal tube. So it's a pressure which is upstream the volume which is going to be delivered to the patient. And this pressure is monitored. So you see on the bottom part the screen with numbers, and alarms can be set to limit the peak pressure, for instance, which we will describe shortly. So the basic question is why does ventilation generate pressure? Why pressure is needed for insufflating the lung and ventilating the chest? So if we say that pressure is force, there are two main forces which are opposed to the entry of gas in the chest. And to counteract these forces, so to make the volume going into the lung, the pressure is needed. When a patient is breathing spontaneously, this pressure is generated by the respiratory muscle and it's negative pressure. When it's a ventilator delivering the pressure and it's positive pressure. And there are two main forces. One force is the resistance to airflow, to flow. And this is due to the tubings, the endotracheal tube and the airway. And the other force is the elasticity of the lung, which creates what we call the elastic recoil of the lung. So remember, the pressure is needed because forces are counteracting the entry of gas, and there are two main forces, resistive forces and elastic forces. So the pressure can be more or less elevated, and what makes the pressure becoming more or less elevated? First, the quantity of volume which is delivered and which you can set on the ventilator. Second, the resistive part, which, as I say, is due to the tubing, the endotracheal tube, and the airway. And you may think of patients having asthma, obstructive airway disease, or simply a lot of secretions, who will have a lot of resistive pressure to counteract. Or the elasticity of the lung, which may be more or less stiff if you wish, but also the size of the lung, and I will come back to that. Please keep in mind that the smaller is the lung, the higher is the pressure for a given volume. So what I'm going to describe briefly is what we call respiratory mechanics. And again, is describing the forces which explain this increase in pressure, resistance, explaining the resistive pressure, elasticity or elastic recoil, which is expressed as compliance or elastance, I will come back to that, and which explain the resistive pressure. There are two main modes of ventilation. Modes where you set the volume, and this is called volume control ventilation. And the ventilator delivers a fixed volume which is set by the clinician. Or you have modes where you don't set the volume, but you set the pressure. So these modes are called generally pressure control ventilation. And you have different modalities which are all pressure targeted, but which includes a very popular mode like pressure support ventilation. These are modes where the clinician adjusts the pressure, but not the volume delivered to the patient. Today, we are going to discuss volume control ventilation because this is easier to understand how much pressure is needed. So remember, the pressure resulting from the insufflation of the volume that you set on the ventilator depends on, of course, how much volume you set, the resistance of the patient, including the endotracheal tube, and the elasticity of the lungs and chest wall of the patient. So this is the kind of waveforms you can observe during volume control ventilation. And you can see that at every breath. So it's important to spend a few minutes describing these two waveforms. This is pressure over time. Remember, this is airway pressure, so the pressure at the airway opening, which is measured like at the Y-piece before the endotracheal tube. And the second one is the flow, which is expressed as either positive or negative, and by convention. So usually on ventilator, the positive flow is in fact the inspiration or the insufflation, which means the gas comes from the ventilator and goes into the patient. And the negative part is called expiration, that when the flow and the volume comes back from the patient into the ventilator. I did not display the volume here, which is usually the third waveform on the screen, but just remember that the volume is the integral of flow over time. So it's not directly measured by the ventilator, but just calculated from these waveforms. So this is an example of volume control where, as you can see, the flow is a square, which means that the flow is constant during the insufflation. The expiration is completely different because it's passive, and it looks like an exponential decay, an exponential curve. What I'm going to discuss with you very briefly now is this small phase, which we call end inspiratory pause or end inspiratory plateau. So imagine it's like taking a big breath and holding his breath at the end of inspiration. So you keep the air in your lung, you relax, and this is what happened with this plateau. And this plateau is very interesting because it gives an opportunity for the pressure to go back to the elastic value. I'm going to explain that. So these two pressures you can see are monitored by the ventilator. This one is the peak pressure, very and easy to understand. It's what you get as the maximum pressure. And this one is called the plateau pressure. So the plateau is the pressure you get when you stop the flow at the end of insufflation. And of course, the system is relaxed because your patient is ventilated passively. So this small end inspiratory pause, which you set on the ventilator, is like a pulmonary function test, if you wish, because it will give you the value in the lung in relaxed situation. So let's go back to our explanation about the positive pressure. Pressure is force opposing entrance gas into the lung. One force is the resistance. It's related to the friction of molecules against tubes and airway. And just understand that resistance is a concept which exists only in dynamic conditions. So if you're in static conditions, you have no resistance, because resistance is really what's impeding the entry of gas in a dynamic way. So the other force is the elasticity of the system, which we can call elastance or compliance. But remember, this is the elastic recoil of the system, like a balloon, and it's better measured in static condition. So when you are ventilating the patient during the insufflation, you have both the resistive pressure and the elastic pressure. When you stop the insufflation at the end of the breath, you don't have anymore the resistive pressure, but only the elastic pressure. So this plateau is acting as a pulmonary function test, and I'm going to show you how we use it clinically. When you have this separation between the peak pressure and the plateau pressure, it tells you that this part, so the difference between peak and plateau, was simply due to resistance. So it's a resistive pressure. Whereas this part, the plateau minus the pressure at end expiration, which we call PEEP, positive end expiratory pressure. So this difference here
is the elastic pressure. This is an example of a patient who would have a high peak pressure, but a very low plateau pressure. What does it mean? Well, it means that this patient had very high resistance. For instance, an asthmatic patient or a patient with a very narrow endotracheal tube. This is another patient with the same peak pressure, but a much higher elastic pressure and lower resistive pressure. In this patient, there is a high elasticity or high elastance, and the opposite of elastance is called compliance. So in this example, that would be a low compliance. And when we say high or low, we keep in mind this limit, which is very useful for clinical practice, to say, well, when it becomes higher than 15 centimeters of water, this elastic pressure, it's risky for the lung. It becomes dangerous for the lung. For instance, in ARDS, we look at this pressure, the elastic pressure, we call it the driving pressure, and we try to maintain the driving pressure below 15 centimeters of water. We know it's not always possible, but when it's higher, the patient is at risk. And of course, this pressure can be high because you set the volume which is excessive, or because the lung is very stiff or very low compliance. So driving pressure above 15, which is only the elastic pressure, is at risk of lung injury and barotrauma for the lung, if you wish. So the other clinical parameter which is important is to directly measure this plateau pressure, because this plateau pressure is the pressure in the alveoli at the end of insufflation. And the plateau pressure is another indicator of the risk of ventilation when we ventilate a patient, for instance, with ARDS. So the plateau pressure is a direct measurement of the maximum alveolar pressure during insufflation. And we know that when the plateau pressure is above 30 centimeters of water, the ventilation put the lung at risk of injury and barotrauma. And of course, this plateau pressure can be high because the driving pressure is high, or because the PEEP is high. So this is an important parameter because it may allow you to decide either to adjust your tidal volume or to adjust your PEEP. If you want to be more precise in whether this pressure is risky for the lung, you would ideally want to know what the pressure surrounding the alveoli, and it is called the pleural pressure. I'm not going to describe this, but just to let you know that when we want to know more exactly what is the distending pressure of the lung, we not only measure the plateau pressure, but we also measure the pressure surrounding the lung with an esophageal catheter. And this technique, for instance, is useful for patients who have very severe morbid obesity or distended abdomen, to try to understand what the influence of this obesity or of the abdomen on the plateau pressure. Now I'm going to go through a little bit more details about resistance and compliance, because it is very important to understand what it means for the patient. So as I say, the resistive force corresponds to a pressure dissipation. In other terms, this resistive pressure, you may remember the difference between the peak and the plateau, is a pressure which never goes into the lung. So the resistive pressure does not expose the patient to any risk in itself. You remember this diagram showing a patient with very high resistance. And when I say high, it's clearly higher than 10 or 15 centimeters of water. So of course, this is not good because it means your patient, for instance, had a severe asthma attack. But this high resistive pressure is not going to harm the lung because it will be dissipated against the airway. Therefore, the pressure in the lung is a plateau pressure. So yes, it is a difficult ventilation with very high pressure, but in this case, the pressure by itself is not risky for the lung. Let's now discuss the elastic pressure, the other part. As I said at the beginning, the pressure becomes elevated because of the volume you deliver and because of the elasticity of the lung. And I mentioned also the size of the lung. And this is very important to understand because it has very practical consequences. The smaller the lung, at least the lung available for ventilation, the higher the pressure for a given volume. Let's take an example. So this would be a patient ventilated with a tidal volume of 500 ml, which would be a standard ventilation. And these patients, for a tidal volume of 500 ml at zip, for instance, we'll have a pressure. You remember this is plateau pressure, the one we do when we have a pause at an inspiration, of only 10 centimeters of water. And of course, when we insufflate 500 ml, there is, let's say, approximately 250 ml in each lung. When we calculate what we call the compliance, we divide the tidal volume by the pressure. And in this case, it would be 50 ml per centimeters of water. Let's imagine now that the same patient has a selective intubation when the endotracheal tube, instead of ventilating the two lungs, has been pushed too far and is only ventilating the right lung, which is something which can happen. So instead of having 250 ml in each lung, you have 500 ml in one lung. And intuitively, it makes sense, the pressure will become much higher. So the pressure will, instead of 10, will be 20 centimeters of water, and your new compliance will be 500 ml divided by 20, which is 25 ml per centimeters of water. So you see that nothing changed in the lung itself. It's just that because of the selective intubation, you have only half of the lungs which is now available. So this illustrates that the smaller is the lung, the higher will be your pressure. Why is it important? Because the sicker the patient in the ICU, patient with severe pneumonia, patient with ARDS, like some of the patients with COVID-19 that we see nowadays, have this acute respiratory syndrome, distress syndrome, with at least one half or maybe 2/3 of the lung which are completely non-aerated, non-open. So what you are ventilating is a small lung. That's why we call ARDS the baby lung. And the smaller is this lung, the higher your pressure on the ventilator. Let's finish by having a few minutes about expiration. Expiration is passive. Once you have insufflated the lung, the ventilator just opens the expiratory valve and the pressure goes down. How does the pressure goes down in such a system like the respiratory system? Well, this is known for a long time. It's a system with resistive pressure and elastic pressure, so it's illustrated as resistance and compliance. Such a system has an exponential decay. You remember I showed you on the flow curve that the expiration is exponential. It's true whether you look at the flow curve or the volume curve. And of course, there is a time constant, which means that you need a certain time constant to empty the system. And this time constant depends on the resistance and compliance. So why is it important? Well, if, like in this example, look at the third curve. Here you have, from the top to the bottom, you have the volume, the airway pressure, and you see the small pause. This is volume control ventilation. And the flow, and in this graph, they represented the inspiration down with a square and the expiration up. And you see in this example that the flow did not have enough time to go back to zero. And if the flow is not able to reach zero, it means that the next insufflation will take place before the lung has go to its residual functional residual capacity. And therefore, in this case, even if you see nothing on the airway pressure, there will be some residual pressure inside the lung. That's what we call auto-peep or intrinsic peep or hidden peep, if you wish. So there is positive pressure in the lung, but it is not displayed on the pressure which is measured at the Y-piece. This can be substantial, and look at this example on the left part. You have a patient where you have the tracing of flow. The second one is esophageal pressure. The third one is airway pressure. And in this patient, we knew this patient has severe airway obstruction. We suspected that auto-peep could be present. Look at the airway pressure curve. You see no positive pressure. So the way to measure the auto-peep is to perform an occlusion at the end of expiration. It's called an end expiratory hold. And this is a function which exists on any ICU ventilator. And you see in this patient, this was spectacular because the real pressure inside the lung of this patient was much higher than expected, and in the range of 15 centimeters of water, which had many deleterious effects like hemodynamic depression. So auto-peep will be more frequent in COPD, emphysema, asthma. It has the same consequence as external PEEP or risk of barotrauma. And remember, it's very dependent on the amount of tidal volume and minute ventilation. The higher the volume you deliver to the patient, the higher the risk of auto-peep. Reducing tidal volume and minute ventilation always reduce auto-peep. And auto-peep may also be reduced by allowing longer expiratory time. So this is a brief overview of the pressure during volume control ventilation, and all the examples I took are during passive ventilation when the patient is passively ventilated. So the conclusion of this first presentation is to remember that the only pressure at risk for the patient is the elastic pressure. So this is important to monitor. And the higher the elastic pressure, which can be monitored by plateau and driving pressure, the smaller is the open or ventilated lung. For clinical application, remember that a plateau pressure higher than 30 centimeters of water or a driving pressure higher than 15 centimeters of water both expose the lungs to high risk of injury. We call that ventilator-induced lung injury, and also impose strain on the right ventricle. So ventilating a patient with pressure much higher than that can lead to worsening of the respiratory function, but also worsening of the circulatory function. Lower pressures are considered to be safer, so lower than 30 for the plateau, lower than 15 for the driving pressure, but we don't know exactly if there is a safe threshold, and sometimes we try to get the pressure as low as possible. Of course, we cannot go too low because we still need to ventilate and to give volume to the patient. So when you see this high pressure, it may impose to reduce either the tidal volume and or the PEEP level. The difference between the peak and the plateau is the resistance. It reflects the resistive pressure, which can be due to the tube. It can be a small tube or an occluded endotracheal tube, or it can be due to the airway or to secretions. If you see that the elastic pressure is increased, so we say increase elastance and elastic pressure or decrease compliance, well, it's usually a small lung because of atelectasis, because of ARDS, or because of pneumothorax. During volume-controlled ventilation, it's very useful to set a plateau or an N-inspiratory pause of 0.2 or 0.3 seconds to monitor the plateau pressure and the driving pressure. And as we said, high elastic pressure may impose to reduce tidal volume and or PEEP. Last conclusion, auto-peep. This is something which is not measured by the ventilator. So you need to detect it by looking at the expiratory flow curve when it does not come back to zero. You can measure it by an N-expiratory hold maneuver on the ventilator. It's available on all ICU ventilators. And it has the same effect than SED-PEEP, like risk of barotrauma or hemodynamic effect. So thank you. I will stop there, and maybe with Lorenzo, we can try to go to questions.
Yeah. Hi, everyone. Good evening. Yeah. Can people...
Lorenzo, sorry, I forgot to introduce yourself, so maybe you can...
Yeah, so my name is Lorenzo Del Sorbo. I'm one of the ICU physician working at Toronto General Hospital, here in Toronto, of course. And I'm also interested in research related to mechanical ventilation. So Laurent, one of the first questions is, can plateau pressure be accurately measured in both volume control and pressure control ventilation? That's, I think, is a good question.
Yeah, very good question. So the first thing is to measure accurately P-plat, you need a passive patient. So this is simple to measure when the patient, for instance, is heavily sedated, of course, paralyzed. It's more difficult when the patient is also breathing and assisted by the ventilator. It's not impossible, but it's more difficult. So during volume control, it's very simple to do. You just add this pause, or you do an N-inspiratory hold maneuver, but the pause is sufficient. During pressure control, it's not possible on every ventilator. And the reason is that we consider very often that in pressure control, at least in passive condition, the end of inspiration, the pressure is very close to the plateau pressure. So ideally, one should also measure the plateau pressure during pressure control, but very often people don't do it, in part because some ventilators do not allow to do that.
Okay. Laurent, I don't know if you can hear me.
Yes.
Okay. So let's see, another question here. Does repeated auto-peep lead to breath stacking in patient with COPD or emphysema COPD exacerbation?
Okay, that's a That's a good question. So what we call breast stacking is when two breasts are delivered on top of each other. This breast stacking phenomenon we'll rediscuss in another session this week. Is more often present when patients are triggering very actively and doing like double triggering, for instance, because they are not well sedated and asking a lot of making huge efforts. So auto-peep is not doing that, but what auto-peep is doing is an hyperinflation. We call it dynamic hyperinflation because it's related to the insufficient expiratory time, and therefore it creates the complications of hyperinflation, and the patient can have low blood pressure because of auto-peep, or can be very distended with risk of barotrauma, for instance. So not really breast stacking, but hyperinflation, yes.
Okay. So, Laurent, another question I think you may answer is if you can explain again the difference between driving pressure and plateau pressure.
Okay, so these two pressures are related to the elasticity of the lung, and the lung, which is very stiff or very small, if you wish, will be characterized by high plateau pressure and high driving pressure. What's the difference? So the driving pressure is the delta pressure during the ventilation. The plateau pressure is the pressure you reach at the end of insufflation. So it depends on the driving pressure, but also on your PEEP level. So we could say the plateau is the sum of the PEEP and the driving pressure. And if your plateau is high, but your driving pressure is okay, it means that you need to reduce the PEEP. If your driving pressure is very high, even if your plateau pressure is not high, it means you need to reduce the tidal volume. So to make it simple, plateau pressure is related to both PEEP and tidal volume, whereas driving pressure is related only to the tidal volume.
Okay, so one more question is, they're asking if physiotherapy or chest physio is contraindicated when the patient experiences or is ventilated with high pressure, because that may further increase the pressure and become even more injurious.
Okay, so we don't know exactly, but we think that when you do chest physiotherapy, what you do mainly is to increase the pressure on the chest wall. And what's really injurious for the lung is the pressure distending the lung. So this is a bit different. Having a pressure generated by the chest wall is something, for instance, we see when patients have an abdominal distension. So I know it's different from chest physiotherapy, but it's to illustrate that when the pressure is external to the lung, it is not distending the lung. So we could say maybe chest physiotherapy techniques are not distending the lung if you don't, except if you bag the patient very heavily. But if you just push on the chest, this is not creating dangerous pressure.
Okay, so there's one interesting question. You didn't really talk about pressure support ventilation, but they're asking if plateau pressure can be measured also during pressure support ventilation.
Okay, very interesting question. So I think we will describe tomorrow the assisted modes and like pressure support ventilation. So this is a mode where the patient is receiving pressure, but is also breathing at the same time, so is assisted. And traditionally, we were not used to measure the plateau pressure. in fact, it is not possible on every ventilator. But when the ventilator makes possible to do an inspiratory hold, then you can try to measure the plateau pressure. And the surprise is that in many patients, it's possible to measure the plateau pressure. But then you have to be to remember that it's very different than passive ventilation, because during passive ventilation, all the pressure comes from the ventilator. During assisted ventilation, part of the pressure comes from the ventilator, part of the pressure is generated by the respiratory muscle. And when you do the plateau pressure, you add the two. You add the pressure delivered by the ventilator to the pressure generated by the muscle. This is why during pressure support, the plateau pressure is usually higher than the peak, which of course can be surprising if you're used to measure plateau pressure during volume control ventilation. So the answer is yes, it is possible. It's not possible on every ventilator, but what you will see is a plateau pressure which is higher than the pressure delivered by the ventilator.
Very good. There was one of the question asking why at some mics you always use volume control, whereas at UHM we always use pressure control ventilation. That's more. I don't know if you want to address that for a second, the difference between the two modalities.
Yeah, and again, we'll try to address that. So basically, for the patient, it does not make a big difference if it's pressure control or volume control when it's passive ventilation. The reason why we use volume control very often is because there are very strong recommendations about controlling the volume in ARDS. So we start with volume control ventilation, which is easier for that. And the second reason is that it allows to measure the respiratory mechanics, as I've seen on the slides. When it comes to assisted ventilation, things are different between the two modes. But again, in terms of what the patient is receiving, whether it's with volume control or pressure control, it does not make a big difference for the patient.
Perfect. And then, Laurent, there was another question asking if you can repeat or explain again the difference between PEEP and intrinsic PEEP.
Right. So PEEP means positive and expired pressure is something that you adjust yourself on the ventilator. You set, for instance, the PEEP at 10 centimeters of water. It means that the patient expires from the plateau, and when the pressure reaches 10, the ventilator will maintain this pressure. But the pressure which is maintained by the ventilator is measured in the ventilator itself. If you have a partial obstruction in the airway and you need a long time to expire everything, you may still have the pressure inside the lung while the pressure on the ventilator is your PEEP of 10. And at the end of expiration, the pressure inside the lung may be higher, maybe much higher than the PEEP you have set on the ventilator. So for instance, you have set the PEEP of 10, the pressure inside the lung is 15 centimeters of water. So there is an intrinsic PEEP, which is 5 centimeters above the external PEEP, which means that inside the patient, the total PEEP, if you wish, is 10 centimeters of water. The problem with this auto-peep or intrinsic PEEP is that it's inside the lung, so it is not measured by the ventilator.
Perfect. And Laurent, another question is to explain what role the weight of the chest and abdominal contacts have on modifying the airway pressure, and if positions of the patient can affect that.
So this is the situation where the plateau pressure, for instance, may be increased, not because you have a lot of distension of the lung, but because what's around the lung is pushing very strongly on the lung. So if your abdomen is distended, your pleural pressure will goes up and the pressure around the lung will be high. So you may measure plateau pressure, which is high, but it's not reflecting a distension of the lung. It's reflecting what we call a high pressure due to the high intrathoracic pressure, if you wish. So if you calculate what we call the transpulmonary pressure, so in the airway minus in the pleural space, this transpulmonary pressure will not be increased because a large part of the increase in plateau pressure will be due to the abdomen. It's just important to know because you may accept, for instance, in that case, to go to higher plateau pressure than 30 centimeters of water if you think that you have at least 5 centimeters of water or more due to the chest wall.
Excellent. Thank you very much. All right.
Thank you very much. So maybe, Lorenzo, it's time to switch and I have to stop sharing my screen to your presentation. And, and Lorenzo, who is also in charge of the research on the ECMO program at Toronto General Hospital, for instance, is knowing very well the complicated issue of gas exchange, and so he's going to tell us about the basic principle of gas exchange under mechanical ventilation.
Thank you, Laurent, for the presentation. Thank you. Good evening, everyone. So I don't have any conflict of interest to declare, and in the next half an hour, I'll try to explain the principle of gas exchange, talking about gas exchange abnormalities, some physiologic principles, and go through some clinical cases. Okay, next slide, please. So most of the information that you will hear from me are taken from these very nice publications on the Blue Journal of only a few years ago. So it's very worth reading these very clear, sometimes a bit too much in depth, but worth reading again. Next slide. Okay, so there are two major gas exchange abnormalities that we're going to address. One is hypoxemia, which is low PaO2, usually lower than 60, and these numbers 60 is derived from the hemoglobin oxygen saturation curve, which is sinusoidal. And you can see, and I think everyone knows, that the point of flexes here correspond to 60 of PO2 in normal patients, which correspond pretty much to 90% of oxygen saturation. The other major gas exchange abnormalities is hypercapnia, which derives from increased CO2 production or impaired CO2 clearance. The physiology there is very different because the CO2 is very soluble and very permeable, so crosses the alveolar capillary membrane very, very easily. Next slide, please. So there are several mechanisms that are listed here that causes hypoxemia. So it's hypoventilation, so reduced amount of air arriving to the alveolar units, decreased pressure of the inspired air or oxygen, decreased diffusion, VQ mismatch, so mismatch between ventilation and perfusion, shunt, and decreased oxygen venous oxygenation. So we're not going to talk about decrease in of the inspired pressure of oxygen, which is relating to high altitude hypoxemia. Decrease of diffusion is not very common in patients that are mechanically ventilated in ICU. So we'll be focusing mostly on VQ mismatch and shunt. So next slide, please. So here's the concept of ventilation perfusion matching or ratio. So on the y-axis, you have the pressure of oxygen. On the y-axis, you have the pressure of CO2. On the x-axis, you have the pressure of oxygen in the alveolar space. And you have the change of the ratio between oxygen and CO2 based on the VQ relationship. So the ideal VQ relationship, as you can see in the middle here, is about 0.8, which is correspondent to the ventilatory ratio, the respiratory quotient. So the amount of oxygen and CO2 that are optimally exchanged in our lung in a healthy condition. And this ratio can change in pathological condition versus a condition of no ventilation and full perfusion, which is called a shunt that you can see on the left hand, or the opposite, which is dead space with normal ventilation without any perfusion. Okay, and the gas exchange abnormalities really depends on the distribution throughout the lung parenchyma in pathological condition of these ventilation perfusion matching. Next, please. So in this next slide, you can see that on the x-axis you have increasing ventilation perfusion ratio. You can see the effect in physiological condition, pathologic condition of these on the content of gas in the alveolar space. So let's go one by one through the main and to the most distant relationship between ventilation and perfusion. So we said that shunt is the absence of ventilation in presence of maintained perfusion. So here is the example of an alveolar unit that is perfused by venous blood, which has 40 millimeters of mercury of O2 and 46 in this example millimeters of mercury of CO2. Since there's no ventilation, you can see on the opposite side, which would be the the pulmonary vein, reaching the left part of the heart, that the content of PO2 and CO2 are not changed. Okay, so if a patient is hypoxemic, in this condition will remain hypoxemic because there's no ventilation occurring, so no gas exchange occurring in this condition. The same for CO2. The CO2 in the blood won't be able to be dissipated through the alveolar capillary membrane. So next, please. Okay, so in this slide, you can see a representation of a slice of the lung, okay, with at the bases, some alveolar units that are very collapsed. This is a representation of what it can happen in a patient with the ARDS, for example, or by basal atelectasis. So at the bases, there are alveolar units that are collapsed, okay? And here is where the shunt occurs because there's no ventilation and the perfusion will be maintained in these areas. Whereas as we go to more ventral areas, you can see that the alveolar volume or aerated volume in the lung is increasing. So the ratio between the ventilation and perfusion will be changing. Next, please. Okay, so in this slide, you see a picture of a CT of a patient with the ARDS. You can see at the basis that there are some areas of consolidation, and in the cartoon, the venous blood is going through the lower zones, remain with the same oxygen content, okay? Whereas the venous blood going to the upper areas of the lung with some ventilation gets oxygenated. And the resulting oxygenation or the resulting gas exchange really depends on the proportion of these two areas. If you want, if you're interested, I put the equation, which really is being used at the bedside, with the equation to measure the shunt quote. Next slide. So here is then measure that we can take, or the treatment that we can apply to our patient with hypoxemia. Okay, so we can increase FiO2, okay, although by increasing FiO2 in condition of shunt, it won't be extremely effective if the shunt quote is very, very represented. As Dr. Brochard was saying in the previous presentation, in patient with the ARDS with up to 2/3 of the lung being consolidated, you might not be able, just by increasing FiO2, to increase the content of oxygen in the arterial blood. So really, the major maneuver to be attempted to improve oxygenation is to try to recruit those areas of alveolar collapse, okay? And this can be done in different ways, which I think will be addressed in the future talks in the next few days. But just briefly, one is to increase PEEP, so the positive and expiratory pressure, which maintains the lung in a more recruited state. We'll have few slides later about these as well. Do recruitment maneuver, put the patient in a prone position, okay? Or use inhale vasodilator to optimize the perfusion of the vessels of the area of the lung that are ventilated. And we'll go through some of these issues while we're explaining some clinical cases. Next. So the other major gas exchange abnormality derives from the presence of dead space. And as we said earlier, dead space is the presence of ventilation in areas of the lung that are not perfused, as represented in this schematic picture. So again, here, venous blood that arrives to the alveolar unit may cross these alveolar unit without exchanging any gas, because going through some areas of anatomical shunt. And in this case, because the CO2 cannot be really released because of the lack of perfusion of this area, the CO2 tend to increase as the CO2 production is maintained constant, given the same CO2 production in this condition. In fact, in the upper part of the slide, you can see that the arterial pressure of CO2 depends on the ratio between CO2 production on the numerator divided by alveolar ventilation in the denominator. And the denominator can be composed by multiplying respiratory rate, okay, times total volume, and actually the alveolar ventilation total volume minus the dead space, okay? So it's clear that to try to decrease CO2, we need to increase alveolar ventilation. We may do that by increasing respiratory rate or increasing total volume, because in this condition, you will increase minute ventilation, and by obvious mathematic computation, the arterial pressure of CO2 will decrease. So the fraction of that space is playing a very important role in controlling CO2. Next, please. So this is very important, especially in the upper part of the lung here. As you see, the ventilation in this upper, more ventral part of the lungs is very represented, okay? And this area of the lung may be not as perfused by gravity condition as the lower part. And so the ventilation perfusion ratio may be very, very close to that space, especially in certain conditions that we'll see later on in some of the slides. This is not, next please. So that space is not important only because it's affecting CO2 and CO2 clearance, but also because it's being very importantly, study and correlated to mortality. So this is a relatively old paper published on the New England Journal of Medicine, showing as the mortality progressively increases as the dead space fraction also increases. Next. So as dead space is very difficult to measure accurately at the bedside, several investigators have concentrated their research focus on studying potential surrogate. And one of the best surrogate for dead space that we can easily measure at the bedside is the ventilatory ratio. You can look at the formula online. It's very easy, but it's the ratio between the product of measure mini ventilation times the measure CO2 divided by the predicted mini ventilation and ideal CO2. Okay, so the higher is the ventilatory ratio, as demonstrated by this plot, the higher is the dead space quote. And also ventilatory ratio has been strongly associated with survival, as shown in the lower table in the slide. You see the odd ratio, the highest odd ratio in this multivariate logistic regression associated with the mortality among all these other parameters. Next slide. So in patients with high CO2 hypercapnia, the measure that we can take at the bedside to try to correct that is increasing respiratory rate, increasing total volume. These are not effective in us. We can reduce CO2 production by deepening sedation or using neuromuscular blockade. Okay? We can increase total volume, and probably you'll hear about these in the next few days, by increasing inspiratory time or increasing the inspiratory pause. And we always have to try to decrease dead space as much as possible, considering dead space not only the physiological, pathological dead space in the patient, but also the instrumental dead space that the patient is attached to when he's connected to a ventilator. Okay, so trying to get that as small as possible. Next slide. So we'll go through some clinical example. Okay, so the first one here is a patient with ARDS, ventilator in volume control, 430 ml for 25 breath per minute with the positive end expiratory pressure, so PEEP of 15, and this generates a plateau pressure of 27. The patient is ventilated with an FiO2 of 40%, and the resulting PO2 is 53. So by definition, this patient has maybe his normal CO2, 38, but he's hypoxemic. The PF ratio is about 130, 132 precisely, and below is the representation of these CT scans. So this could be a potential, a typical ABG of a patient with ARDS as represented here. And we know that PF ratio, according to the new Berlin definition of ARDS, is indicating the severity of the patient. So it's very important to measure PF ratio, not only to try to address potential hypoxemic condition, also to understand the severity of the patient. So in this case, the PF ratio is 132, so the patient would be classified as having moderate ARDS. Next slide. So this is important because the mutually exclusive category of ARDS are also associated with different mortality risk. And this has been studied also a number of years ago in this publication, Intensive Care Medicine. As you can clearly see, the mortality rate decreases as the PF ratio gets higher. Next. So as we said, one maneuver we can do to try to correct that hypoxemia is to increase FiO2. So that's unless the quote of shunt is very high, that could potentially correct the issue of hypoxemia. We have to be very careful about our target, because hyperoxemia is also dangerous because it increases the oxygen toxicity. And there have been recently some publication about this interesting issue. So be mindful when you increase FiO2 that you can induce oxygen toxicity in these patients. Next. By increasing FiO2, the other risk is to induce reabsorption atelectasis. In this table, you clearly see that the FiO2 was increased from 40% to 100%. In this case, the PO2 dramatically increased to 94 to 300. You can see that the quote of shunt went from 16 to 22, suggesting that part of the lung have collapsed, and so there was really a reabsorption atelectasis going on. Okay, so be extremely careful when you're trying to manage FiO2. Okay, so next, please. So second case. So it's another case of a patient with ARDS, ventilated this time with volume control ventilation, 300 ml for 27 breaths per minute. PEEP is again 15 centimeters of water, generating at this time plateau pressure of 30, which, as Dr. Brochard mentioned earlier, is a threshold that we consider according to guideline. This patient requires 100% of FiO2, so that cannot be increased any further, and the PO2 is only 40. As we can see here in this cartoon, there is major part of the lung is really collapsed. You see the alveolar units are really small. And so there is a lot of shunt, as you can see projected on the curve of the VQ matching, okay? And so it's very difficult to provide good oxygenation. Maybe not so much for ventilation, because even small unit of aerated area of the lung can allow for enough CO2 clearance given the high solubility and permeability of the alveolar membrane to CO2. So here we can, as I mentioned before, we can apply a recruitment maneuver, or we can increase the PEEP. So next slide, please. So that's what we did in this case. You see, we went from PEEP of 15 to PEEP of 20, and that would have led to an increase in plateau pressure, so the total volume was slightly decreased. But this allowed, in this case, you see, to recruit the lung. So the VQ matching, or the distribution of the VQ matching in this condition with some recruitment, really changed. Okay, and so there is less shunt, and by consequence, the PO2 is increased, allowing in this case even to FiO2 to be reduced to 70%. Next. So if we do exaggerate with the recruitment maneuver, or we increase the PEEP to an excessive level, so here you see we didn't, in this condition, we maintained total volume as the original one to 320, and the PEEP was increased to 20, and the plateau pressure then increased to 32, okay? So this is an excessive recruitment, okay, leading to some over-distension. So you can see here, there's no collapse area in this lung, but there are areas of the lung, especially in the ventral zones, that are hyper-distended. And so we are generating, okay, areas of that space, and these will increase likely the CO2. In fact, the CO2 in this case was increased from 38 to 54, okay? Because that will create two issues. One, create some areas of that space, and potentially we would redistribute the perfusion of the lung toward the lower zones where the VQ matching is not as advantageous. Next, please. Okay. We can encounter also patients that are not recruitable at all. So if we increase the PEEP, although we may correct for total volume, okay, we may not achieve any lowering of the shunt quote, and the patient will experience then more hypoxemia or persistent hypoxemia and worsening clearance of CO2. So that's why in certain conditions, especially in patients that are not recruitable, or if we apply excessive pressure to the lung, okay, the major issue in patients, especially in patients with ARDS, may not be really hypoxemia, but CO2 clearance or dead space. And that's why, and this is the pathophysiological base that drove that study showing that that space quote is correlated to survival in these patients. Next, please. I'll briefly talk about the recruitability, since it was a matter of this last clinical case. Recruitability is very widely distributed in normal ARDS. There is a lot of discussion in these days about luritability in patients with ARDS from COVID-19. In this paper, very nice paper by Luciano Gattino in the New England Journal of Medicine, you can see that the amount of potentially recruitable lung is very widely in different patients. Next. This has been studied by other investigators. My colleague in Italy, Salvatore Grasso and Vito Fanelli, clearly divided the patient in recruitable on the left side. You can see by increasing airway pressure, in this case, increasing PEEP, you may get higher recruited volume, whereas the recruited volume remains exactly the same. So there's no recruitability as shown on the right side of the slide by increasing airway pressure. Next, please. And importantly, this recruitability may be associated to survival, as Johan Golliger demonstrated, and Johan will be a speaker in the next few days in this course. He demonstrated that patient that has a response in terms of oxygenation, so increase in PF ratio by increasing PEEP, okay, so patient that have some recruitment induced by, potential recruitment induced by increasing airway pressure, have a lower mortality. Okay, so that's very, very interesting. Okay, next. So we have a third case here. Okay, another patient with ARDS. You see the CT of the patient on the left hand here with the hand side in supine position, okay, which is a typical CT appearance as we saw also in the previous slides. Patients ventilated in volume control ventilation with the 27 respiratory rate, PEEP of 15. The plateau pressure is high. The patient is having 100% of FiO2 with the PO2 of 70. And the CO2 is also non-normal in this case, is about 45, which is considered sort of threshold to keep in mind. So it's 52 in this condition. So the patient has been put in a place in a different position, so in prone position. And this prone position has several physiologic effects that you may hear about later on, okay? But definitely changes completely the ratio of ventilation versus perfusion, okay? Because the perfusion may not change as much as the ventilation, so making in prone position, the dorsal area of the lung with the optimal VQ matching. So if you go to the next slide, you see that in several studies, prone position has been shown to effectively increase oxygenation. And we know now that also improves survival after the paper published by Claude Guérin a number of years ago in the New England Journal of Medicine. Next. However, the increase, this is a complicated and very populated slide that has an important message that the change in oxygenation by proning patients, or going from supine to prone position, the change in oxygenation may not be so related to outcomes. So next slide. So the improvement of outcomes related to prone position may derive to an effect on ventilator-induced lung injury. So the injury induced by applying excessive pressure to different region of the lung. And this comes from a different distribution of the pressure in the lung. As you can see in the right-hand side of the slide, okay, the swing in pleural pressure in blue is definitely and dramatically decrease, okay, going from supine to prone condition, prone position, okay? So this makes the ventilation, the distribution of ventilation through the lung more homogeneous, okay, with the consequent more homogeneous distribution of the VQ ratio, okay? So with better gas exchange. Okay, next slide. So this is another case of a patient with ARDS post-trauma. So this patient has a relatively low blood pressure, 90/60, with a high heart rate. The hemoglobin 71 and the lactate is high, is 5.1. So the venous oxygenation is, mixed venous oxygen saturation is 50%, and the patient is ventilated with the volume control 480, 27 of respiratory rate, and PEEP of 16. Plateau pressure is 30, and FiO2 is already 100, with a PF ratio that is very worrisome. Okay, so we have 40 of PF ratio here, given the FiO2 of 100 and PO2 of 40. So here, this patient has ARDS, okay? So part of the lung or the alveolar space are completely consolidated, represented here in the alveolar space in black, and part of the lung is actually working well in pink. So there is a, let's say 50% of shunt coat, okay? So even if we are able to oxygenate the hemoglobin to 100% in 50% of the perfusion to the lung, the rest, the other 50% remains at 50% because of the shunt. And so if we mathematically measure 50 plus 100 divided by 2, the patient oxygen saturation will be 75%. So the only way here, one smart way to correct these issue, these hypoxemic condition, is actually to increase SVO2. So if we go to the next slide, by giving, so resolving the shock, the condition of shock, so in this case, transfusing hemoglobin, you see the hemoglobin went from 71 to 95. So we increase, first of all, the carrying oxygen capacity of the blood. We decrease the lactate, so the patient oxygen extraction also is lower. The SVO2 is 80, and now you can do your math, 100 plus 80, even if there is a 50% of or unchanged shunt, okay? Now you can do 100 plus 80 divided by 2 is 90%, okay? So just by resolving the shock without changing any condition in the lung, okay, we are able to improve oxygenation. So here we are matching the delivery as written in the delivered oxygen as written in the upper side of the, in red of the slide, the ratio between oxygen delivery and oxygen consumption. Next slide. And better shock, better control of the shock leads to better perfusion, and better perfusion not only of the distal organs, but better perfusion of the lung itself. And so in this condition, we'll have a better perfusion of the ventral part of the lung, as shown in this CT slide with the red arrow. And so a better VQ matching, which also leads potentially to less shunt. Next. So we have a case, another case, the fifth case of ARDS. So this patient has severe ARDS and failed prone position, meaning that even in prone position, the oxygenation, the PO2 didn't improve. remain 40 with 100% of oxygen. So one rescue treatment that you may try in this condition is to try to improve perfusion only in the ventilated part of the lung. And so if you give any vasodilator systemically through the bloodstream, you wouldn't achieve vasodilation only in the ventilated part of the lung. Okay, so to do so, a smart way that is being implemented is to deliver vasodilator through the airway. So only the ventilated part would have this effect. By consequence, the ventilation perfusion matching would be better with an increase in gas exchange, in oxygenation in particular. Next slide. As shown in these three graphs, where you can clearly see the effect of implementing nitric oxide to 1836 parts per million. Usually we use nitric oxide to up to 40 parts per million. And of course, this has an effect also on the pulmonary arterial pressure because of the vasodilatory effect of INO. I insisted on these, although it has been shown not to improve outcome in patients with ARDS, but there are a lot of trials going on trying to study the role of high concentration inhaled nitric oxide as an antiviral measure. So I thought that we need to be more familiar with the applications of these kind of treatment. Next slide is the sixth case. We are almost at the end. So this is a patient with COPD exacerbation, and the highlight here is the intrinsic PEEP increase. Okay, the patient has an intrinsic PEEP of 18, which may cause, next slide, please, cause a higher quote of dead space. You see that there are a lot of alveolar units here with a higher dead space. And high CO2 here can lead also to some hypoxemia because of the alveolar gas equation. But increasing FiO2 will definitely improve the oxygen content and improve PaO2, but will also determine a change in hypoxic pulmonary vasoconstriction, and taking into account also, and therefore a change in VQ mismatch, and a change in the respiratory drive, and altogether these may not be as advantageous with the potential higher or further increase in CO2. Next slide. So the real issue in these patients would be to try to decrease the CO2, would be as shown on the right upper part of the slide, to decrease the trapped volume, the hyperdistension, this intrinsic PEEP. And we do that more complicated. I cannot address that in a few seconds here, but to make sure that we try to increase the expiratory time as much as possible. So the expiratory flow, which is impaired in these cases, will have enough time to decrease the amount of the volume of air that is trapped in the lung. Next slide. Almost at the end. So we have a case here of a pulmonary embolism. Pulmonary embolism is a classical example of dead space, because we have the patient with PE will have entire areas of the lung that are ventilated but not perfused. And the dead space we know is leading to an increase in CO2, but the real PaCO2 that you're going to measure depends also on the response to the increase in dead space of the respiratory drive. And since CO2 we know is very, very soluble and permeable, it may be still clear efficiently, but the part of the lung that is not affected by PE. And so the major issue will be remaining, the major issue of the patient will be hypoxemia and various level of CO2, unless the P is so massive that the dead space cannot be compensated with an increase of minute ventilation, so respiratory rate and total volume. Next slide. This is my last case. So if we are in refractory conditions of respiratory failure, we increase all the pressures on our ventilator, we are maximum FiO2, and still the patient has a horrible gas exchange, okay? So has a high CO2 and a very low PO2, okay? And is not recruitable, so we tried all the measure we've been trying to explain in the previous slides. Next. We have the only remaining possibilities, again, to increase the SVO2, okay, to overcome the large quota of shunt. Next. And we can do that very efficiently by providing gas exchange with VV ECMO, okay? So VV ECMO provides an increase in SVO2 and CO2 clearance before the blood reaches the lung, okay? So that's very, very effective. Comes with a lot of complications from a different level, but is very effective. So next again. So my conclusion, be mindful that hemodynamics, so blood pressure, heart rate, and cardiac function are impacting gas exchange. To have a good grasp on gas exchange, you need to know some physiologic principle. ARDS is an hypoxemic syndrome, but the clearance of CO2 plays a major role in managing these patients and on their outcome. Next, please. In refractory cases, then you are forced to think out of the box, and the box in this case is the lung or the chest, and so you need to consider extracorporeal life support or gas exchange. Thank you very much.
Thank you very much, Lorenzo. I think we are a bit late, but we started with 5 minutes late, so we'll take 5 minutes for questions.
Okay.
And there's I start with a $1 million question. How do you determine the best PEEP, and what is your strategy?
Yeah, so it's a very, very good question, and so good that many investigators around the world are trying to address that question without a good answer. So there are physiological way of determining PEEP at the bedside by measuring, titrating PEEP to plateau pressure, or there are other ways to titrate PEEP using PEEP FiO2 tables. So by increasing PEEP as the FiO2 requirements increases. And so these are all been the focus of several large randomized clinical trials, and none of them have reached a conclusive strategy or the best strategy. So we know the guidelines that have been published a couple of years ago suggest to use higher PEEP strategy in patients with more severe ARDS. That's the only recommendation I would give. I don't know, Laurent, you're an expert because you've been involved in many of these trials. I don't know if you have any other specific recommendation.
Well, Lorenzo, so they want very hard to know what's the most practical way to assess recruitability at the bedside, and or how do you assess recruitability at the bedside? So I think a lot of questions about that.
Yeah, so it's a very, very good question, very relevant from clinical perspectives. So there are several ways. So one way is to increase airway pressure in the lung. You can do that by doing a recruitment maneuver or increasing PEEP, and then do a ABG after that. You would expect, first of all, the oxygenation to improve, the CO2 to decrease, and this is a consequence of a better VQ matching, but also the compliance of the lung would increase. Okay, so your ratio between delta volume and delta pressure would be higher. Okay, so total volume divided by plateau pressure minus PEEP would be higher. Okay, that's one way to do it. There is a more sophisticated way that you, Laurent, and Lu Chen develop, which is measuring the ratio between the compliance of the baby lung to the compliance of the recruitability lung. I think these are a bit too complicated to be addressed in few seconds in this.
Yeah, Tom Pireno will be discussing tomorrow, so he did video
Perfect.
to show how to do that, and that may be the simplest way to go to see this video. So we'll ask him to present it to you. So there are two interesting questions. One is regarding your slide where you were mentioning that you over distend the patient, you have over distension. How can we tell it is a case? Is it you looking at the ABG, or is there another parameter that tell us the over distension?
Very, very good question. So we can look at the ABG because if we, by increasing airway pressure in the lung, we'll see the gas exchange to get worse and worse. Definitely, it means that we're doing something wrong to the patient. Okay, either we are over distending or we are redistributing the perfusion in areas that are not healthy, area of the lung that are not healthy. And there's no let me see, if we our airway pressure, the airway pressure that we are delivering is above the threshold that are recognized as threshold to understand if the patient is a higher risk of over distension, also we need to be careful. And I remind everyone, these thresholds are 30 centimeters of water of plateau pressure and 14 centimeters of water of driving pressure. That doesn't mean that we can do anything we want below those thresholds, because as Dr. Brochard said before in the previous presentation, it's possible that the lower these pressure are, the better it is. So that means the lower the risk of over distension it is. So the only real way to see visually if areas of the lungs are over distended is by doing a CT, okay, which is very cumbersome, and I wouldn't recommend to do it in routine clinical cases. And the only interesting thing about doing a CT, that you'll realize that just like the consolidations area that are dishomogeneously distributed, also areas of over distension may be very dishomogeneously distributed and not necessarily distributed with the ventral to dorsal position. So even a small area of atelectasis can induce perimetral over distension. So regional over distension is really, really important, a real important severe issue.
And in the ABG, a substantial increase in PCO2 may indicate also that you have over distension.
Absolutely. Yeah.
So there is maybe just I will address one, because there is a question about whether it's reduced diffusion due to inflammation, increased capillary to alveoli distance. So I understand the concept, but it's not what we call diffusion. It's still shunt, which means that the gas cannot reach the alveoli, so it's not diffusion per se. There was a question about when do you go to, well, or what do you do if the patient is not recruitable? Do you prone? Do you go directly to ECMO? What would be your recommendation?
Yeah, my recommendation is always try proning, okay? Because the different distribution of airway pressure, or more homogeneous distribution through the lung of airway pressure, may greatly improve gas exchange. And proning is very effective in making the distribution of ventilation more homogeneous. Plus, these would decrease also the risk of ventilator-induced lung injury, as demonstrated in many experimental and clinical studies. So I would always recommend to prone patient with ARDS and PF ratio less than 150 for at least 12 to 16, better, the longer the better, hours every day. Okay, these are the criteria, the methodologies used in the New England Journal of Medicine published by Guerin.
There is a question of someone who read Gattinoni's paper about the phenotypes in COVID patients, the L for low and H phenotypes. I don't know if we have time to go in there. And the question is asking what's the difference in shunt and dead space characteristics in L versus H phenotypes.
So I think I can only say that in these COVID patients, the pattern or the features of ARDS are a little bit different from what we always observe at the bedside in other type of ARDS. And the quote of that space may be higher due to some vascular issue. So that I would stop there, and then I would let the
another question about COVID is to say, well, it seems that COVID-19 lungs are not as stiff as other cases of ARDS. Does this change your initial approach to managing these patients with ARDS?
Yeah, so it's true that the compliance in many of these patients is not as low as in other cases of ARDS. So I still use 6 cc per kilo of predicted body weight of top volume. And I would try to address recruitability to understand what PEEP to use, considering that high PEEP, if it's not associated with the recruitment, may only come with some side effect on the right side of the heart and with the higher risk of overdistension. So I would be careful and carefully titrate PEEP, maintaining the same target as usual.
Yeah, I think it's a good point. I think we don't know enough about the COVID patients, but in general, if you see a high compliance, remember the compliance depends on the size of the height. But if you see a high compliance, you may suspect that the lung is not so small, and you may be very careful with PEEP. Okay, so I think we took, it's now almost 7:40, so thank you everybody for joining tonight. As you know, we'll do that for 4 days in a row. So if I look at the program tomorrow, you will have 3 presentations. Neil Ferguson about basic modes of ventilation, Ewan Golliger about risk and complication of mechanical ventilation, and Thomas Pireno about how I set a ventilator and what I monitor. So we'll start again tomorrow at 6 p.m. Thank you very much, and good night.
Good night.